Okay, we'll start. So my name is Greg Dickerson. I'd like to welcome you to our Masterclass Series 2021. I am the Managing Director for LexisNexis in the Pacific region. And today's Masterclass, I'm very, very excited about. It's Employees and COVID-19, Issues and Consequences. And we've got an excellent panel, a very exciting panel where we're going to be able to delve into the issues of the epidemiology, and the consequences of the epidemiology of COVID-19, and then obviously the impact on employment and our employee relations and what we can and cannot do when it comes to managing outbreak from a workplace perspective. First, though, I'd like to show my respect and acknowledge the traditional custodians of the land, of elders past, present, and emerging, on which this meeting takes place. In particular, for us, we're in the north of Sydney, the Camaragal people, but also wherever you may be, for the custodians, wherever you are. So introducing our panel. First up, Professor Mary Louise Mcclause. Mary Louise is a Professor of Epidemiology, Hospital Infection and Infectious Diseases Control at UNSW, Deputy President of the UNSW Academic Board, and Water Health Leader for the Global Water Health Institute. In February 2020, she joined the World Health Organization's Health Emergencies Program Experts Advisory Panel for Infection Prevention and Control Preparedness, Readiness and Response to COVID-19. So very early in the outbreak, February, when we only really knew about the outbreak early in January. And also involved in the World Health Organization's Health Emergencies Program Ad Hoc COVID-19 Infection Prevention and Control Guidance Development Group. Prior to COVID-19, Professor Mcclause was WHO advisor to China and Malaysia during the development of their surveillance for healthcare-associated infections. She was an advisor to several WHO global projects, including the WHO First Global Patient Safety Challenge, Clean Care Saves Lives. And she reviewed the response in Hong Kong and Beijing to SARS in 2003, which, as you may know, was a similar virus. It's also a coronavirus. And she joined the Chief Health Officer's task force evaluating the evidence for the Australian guidelines for healthcare workers. She enjoys mentoring PhD students in building infection prevention capacity in Cambodia, Indonesia, Iran, Malaysia, Macau, Mali, Taiwan, Turkey, and Vietnam. Quite a long list there, Professor Mcclause. It's really exciting to have you on the panel and to get your wisdom and insights.
It's my pleasure to be with you.
Second panelist is Michael Toomer. Michael Toomer is the managing partner of Cloud & Co Australia, as well as the global head of Cloud & Co's occupational health and safety practice. He's recognized as one of the leading health and safety lawyers. While he resides in Australia, his work is truly global. He has acted in matters around the world and is often called upon to review the safety management system of clients in a wide variety of industry globally. Michael holds a Bachelor of Commerce, a Bachelor of Laws with honors, and a Master of Laws. And he's a fellow of the Australian Institute of Health and Safety and a recipient of its Lifetime Achievement Award. He's lectured at the Sydney University, the University of New South Wales, Australian National University, and the University of Auckland, and has written and co-authored over 20 books. His latest book is Mental Health at Work and is published by CCH. Michael, it's really good to have you on the panel.
Wonderful to be here.
And our final panelist, Eunice Blackmore, is a workplace relations specialist lawyer with more than 10 years experience practicing in the UK and Australia. Eunice was most recently a senior associate at Johnson Winter Slattery in the workplace relations team and published extensively during her time at JWS. She previously also worked in Sydney for Ashurst and the UK for Allen & Overy. And she is now a senior legal writer here at LexisNexis for the Practical Guidance Employment module, where she does a brilliant job. It's great to have you on the panel, Eunice.
Thanks, Greg.
So just before we jump into the conversation, which I'm very excited to get onto, a few housekeeping items. If you want to post about this in the social media, please use the hashtag LexisNexis Masterclass. And that way we can follow and contribute to the conversation. And also you will notice on your participant Zoom interface, you can ask questions. So you'll see there's a question button there. If you click on, you can type a question. You can also upvote a question. So if you see that somebody else has put a question in that you're interested in getting answered, please click on and upvote that. That means we understand that it is important. And as it gets upvoted, I will pick it up and ask questions. First, though, we'll also start now with a polling question, just to find out where you're coming from as an audience. And the poll is, are you considering mandating requirements for COVID-19 vaccinations at your workplace? So thinking about your workplace, and the multiple choice answers are yes, yes, based on the job role where appropriate, and no. We have a very wide variety of people on this call, so it'll be very interesting to see what kind of response we get back. I might just give it 10 seconds and then we will jump into the conversation. Okay, we can probably hide the poll now. So first question, Professor Mcclause. I'm very interested to see what's happened in Queensland this week and the reemergence of COVID in the community, especially coming out of a hospital setting. We've also seen the reemergence of COVID in New York, even though there's been quite a high infection rate in the past. So therefore, you could presume that New York is looking at herd immunity. So there's been quite high vaccinations and obviously previous infections in New York. We've seen what's happening in Brisbane. It'd be just interesting to get your perspective on the epidemiology of COVID and, are we doing the right things? And is it potentially going to become an endemic disease for us?
Well, gosh, where do I start? First of all, let me take Brisbane, or let me take Queensland and their quarantine program. So I plotted the data of the number of tests that they've been running and the number of positives of those tests, and also by population. And compared to the end of February to the beginning of March, the numbers jumped by 4 times. So something is going on, and then it jumped at about 7 the next week, and then the next week 9 to 10 times, and then this last week it's stable at 10 times that what it was in late February. So that tells me that there's a trend of more incoming travelers from overseas who are infected. So of course we know that around the world, they're potentially going into a 3rd wave. And even though America has now really picked up on vaccination. So the US in their 5th week, because we're in our 5th week supposedly of vaccination, they managed to get 16 million vaccinated, and at the moment they're at about 40% coverage, and they're at week 14. So they're really catching up, which means that they will be less risk to us. However, the UK has a variant B117, and of course that became the variant, the majority, the big strain within just a matter of months. And a lot of people coming back from the UK and Europe are bringing that variant with them. It's between 35 to 75% or 77% actually more infectious, more transmissible than our strains that we've seen in Australia. So the quarantine program is under a lot of pressure with a lot of infections. And I looked at it, it's about probably 4 travelers per day, on average over the last month or so. So there's a lot of people coming in that are positive. And that puts a lot of strain. Now, this recent outbreak is due to healthcare workers who should have received at least 1 dose. And we do know that Pfizer provides an enormous amount of protection even after 1 dose, after say 10 to 14 days. You get vaccinated about 21 days after the first dose, but they are well protected after the 2nd week. And even if they get COVID, their viral load is considerably lower than it would have been, which means they're at less risk of passing it on. So I'm at a loss to understand why there are 170,000 frontline workers in Australia. That includes 70,000 quarantine staff and 100,000 frontline health workers around Australia. And I find it hard to understand why those 170,000 weren't the first group. And I know that we love our elderly in residential aged care facilities. They were poorly looked after during that second wave. However, they are safe when our frontline workers are safe, and they should have been vaccinated from the get-go. So the situation Queensland is in and Byron Bay is due to the fact that sadly the staff that put themselves at risk and their health every day were not cared for by at least one dose. Does that answer?
I think it does. It starts. I think there's going to be a lot of conversation around that, but I think it absolutely does. I might, from that, switch to Michael, because if you look at it from the perspective of the hospital, can they mandate vaccinations? Are they in a position where they're actually able to do that? And what should you as an employer do from a duty of care perspective?
Yeah, thanks, Greg. It's fascinating to listen to Mary Louise sort of talk about the issue so clearly. Look, the hospitals are probably in a better position than others. I think the hospital could certainly has more room to move in terms of mandating vaccination. But the starting point is that, sadly, for most employers, the idea of blanket mandating of vaccination, as desirable as it might be from a public policy perspective, is not a realistic option for most employers. And a bit of work is required in order to get your business ready to triage what is going to be something that you can mandate and what is something that you can't. There's a number of reasons for that, but there's a myriad of laws that are really designed to give protection to employees in relation to unreasonable directions by their employers. And fundamentally, what we're really talking about here is with an existing workforce, a direction from an employer in relation to being vaccinated. And so the question then becomes, is that a lawful and reasonable direction? Well, in order to justify whether it's a lawful and reasonable direction, some work is required to actually understand whether performing the work that the worker is performing actually requires them to be vaccinated. So we get back to your question. The hospital situation, their frontline workers, they have a high degree of interaction with a vulnerable community in terms of the patients themselves and the broader community. Then one could really see how that could be justified, and it could just be justified in relation to most of the workforce there because of the high degree of interaction in relation to the staff of the hospital. But if you take that away from that obvious example and take it to an office-based example, the position becomes murkier, and in fact, it really becomes much harder to justify how an entire blanket type of approach of saying all of an office environment could be compelled to be vaccinated. So, I mean, sadly and unfortunately, both from a public health perspective, but also from an employer perspective, a bit of work is required to do essentially a risk assessment process and triage the workforce to try and understand for whom is the vaccination really an inherent requirement of their job, which would make it both a reasonable lawful direction, but also give you the protection in relation to discrimination laws that you need, and for whom this may not be, and there is a workaround, and there is the ability to accommodate that person working and doing their job without having to in fact be vaccinated, and ultimately, without that thought process, that careful consideration, a lot of those directions and policies could easily be attacked.
Mary Louise, I can see that there's a question that is directed at you.
Yes, I'll just jump onto that. So
Yeah.
the question there was, can you please comment on the fact that there appears to be no evidence that the vaccine will prevent people from getting the virus? So that obviously comes back into, if it's, the risk assessment, et cetera. But if the vaccine itself doesn't prevent people from getting the virus and therefore transmitting it, is that then mandatory from the perspective of being able to make it mandatory?
It's a good question, and it's complex. So if a vaccine shows that it had, during phase 3 of all the drug trials, of all the vaccine trials, they didn't have the time or the financial ability to test everybody for asymptomatic infection. They only tested you if you reported symptoms. So that person is quite right that from the data, it looks as if vaccines will only prevent severe and death. However, to prevent severe disease means you prevent a high viral load. And if you prevent a high viral load, we are banking on the fact that that means that you most likely won't get even asymptomatic or mild infection. So we're learning an awful lot about the Pfizer vaccine, and most of us won't get the Pfizer, sadly, because we're learning a lot about it, and we're still catching up learning about AstraZeneca, which is a fine vaccine, but the data is still slow to come out from the UK. So in Israel, we know that Pfizer, even with one dose, reduces your viral load remarkably. We're already seeing an enormous drop in numbers because they were looking as if they were going into their fourth wave. So that's good news. AstraZeneca also prevents you from what appears to be any infection at the moment if you are careful after being vaccinated with the first dose for at least 2 weeks. But of course, if you aren't, then I'm concerned about what's called mutation escape, where you give that virus time to use your body as a test tube to work out how to get around an incomplete immune response. But getting back to that question, there is no there's no reason why the logic wouldn't say that we should be protected from asymptomatic infection. Time will tell.
I think this is one of the challenges. It's such an emerging field. There's so much going on that what looks like good advice a couple of weeks ago has changed quite dramatically. It's quite a challenge, and I might throw that to Michael Toomer. You're obviously looking at safety risk assessments when you talking with clients, etc. I mean, surely that's a moving feast in this world, and how do you do that effectively?
Yeah, and it's interesting to hear what Mary Louise is saying, because actually the better the quality of the research around the effectiveness of the vaccination, which is what that question is really getting to the heart of, the greater the justification for mandating it. I mean, in an ideal world, you would have clear direction from government on these issues. But sadly, we're left as businesses to do the hard work of what is in the best interest of the community at large. There are a number of constitutional reasons for that, perhaps, but without getting into them, where we find ourselves is in a situation where businesses have to justify the directions they're giving, and for some parts of the workforce community, those directions are not going to be popular, and there is going to be some resistance to them. The best that a business can do is engage in raising awareness, sharing information, encouraging people to voluntarily take up vaccination, and keeping people informed about the benefits of doing so. So there is a voluntary aspect of this, and a role for businesses that goes beyond the direction and compulsion position. And the greater to take up, the better. But obviously, the better science that you have, better you're armed with that science, the better the quality of your risk assessment, and therefore, then you'll have a better quality justification for relevant directions. So absolutely, the two are intricately related.
Yeah.
May
I suppose
add?
Sorry, jump in.
Oh, I was going to just say, may I add to the complexity here? So everything that Michael has said is incredibly reasonable for those areas outside of, say, health. The authorities aren't making residential aged care facility staff mandatorily take up the vaccine, but I find that ethically hard to accept, given that 75% of all deaths in Australia, or actually it was a bit higher, about 78%, were due to the 689, I think it was, deaths in residential aged care facility. And so there were over 200 outbreaks in Victoria alone. So, and that virus didn't find its way through thin air to get to those very, very vulnerable people. So I cannot understand why it should be mandatory. So you should be given, always given, an opportunity to have one course or another. And the second course should be, if you choose not to have the vaccine, we will find you another job. Because the employer needs to say, this is too dangerous. If your loved one was in residential aged care and they were going to be looked after by somebody who, don't forget, these staff don't earn a lot of money and they often have to work several jobs. So their risk of acquiring COVID is much higher than others who have one job. And so you want to protect them as well, but you also want to protect those that they care for. And it's not one staff per resident. They often look after many residents, and they can't keep that physical distancing of 1.5 meters at all. You can't ask them to wear a mask and a face shield for an 8 or 9 hour shift. So you need to say to them, you've got until the end of October or whenever to make a decision. But if you don't get fully vaccinated by then, we will find you another job.
So that's
just to add to that, Greg, because I think it's important. What Mary Louise is referring to as well in those comments is really the manifestation of the duty of care of the aged care facility. So you owe a duty of care to not only your workers, but also the residents of that facility, and you have to come up with a system in place to make sure that they're safe. So I agree with what Mary Louise is saying, but coming at it from a different perspective. I mean, one of the wonderful things is, and thanks to LexisNexis, Mary Louise and I co-authoring a book for you guys, as you know, on this topic. And the beauty of it is that we come at it from different perspectives, but we arrive at the same conclusion, just looking at the world from a different prism. And that is a classic example of that, where it's the right thing to do, and the science backs it up. But also from a legal perspective, how do you defend your legal position unless you actually try to engage with that risk that you're putting your aged care residents in, if you don't eliminate the risk of contamination of those residents. And even if you get it wrong from a liability perspective in relation to the individuals, that's probably a better place to get it wrong than to get it wrong and lose the life of one of the residents. So there's a very tricky line to be walked there.
Yeah, absolutely. Look at what Alan Joyce has done. Sorry, I was going to throw it to you, Eunice, because that would work in an aged care facility, but how far does that go into general industry? And at what point do you, as a normal employer meaning in that space, what is that? Where's your duty of care? And where does it end? If you see what Alan Joyce, for example, is doing from a Qantas perspective. If I might ask you, what do you think of that?
Okay, well, can I just answer it from a public health perspective? If your disease doesn't impact on anybody else's health, then you have the right to keep that information to yourself, such as during HIV. No one had the right to ask staff if they were HIV positive. No one had the right to sack them because of their HIV status. Because you can't catch HIV from sharing an office or lunch with somebody, or being served lunch, or being a patient of an HIV positive physician, as long as they're very careful about making sure that they don't cut themselves while performing surgery on you. And a lot of them decided to move out of surgery for that reason. But with this one, anything you do with COVID, if you don't get tested, if you don't get vaccinated, you can put somebody's life at risk. And we've seen this poor nurse and her sister have inadvertently infected, I think, at least 5 others. They didn't know they did. Now, we don't know who's going to develop what's called long COVID or long hauler. And that means you don't get over the signs and symptoms for 12 weeks. And we don't even know yet whether or not that has an adverse impact on your health. But the interesting thing is that in the UK, they have an estimated 200,000 long COVIDs, and they're developing special clinics, about 20 of them around the country, to try to look after them. And the scary thing is that if you have a look at the long haul health effects of people who were hospitalized versus those that weren't, who are long haulers, they converge for cardiovascular conditions as long haulers. There's no significant difference. So, but we can't identify who is going to be a long hauler, who is going to have a cardiovascular issue, or severe unpredictable fatigue. So you are putting people at risk by not getting vaccinated if it's deemed legally and ethically that you should, to keep everybody else's health safe. And that's why we ask people to wear a mask.
I was just I can see that there's a few questions on here, Greg, and and thank you very much, everyone. I'm really it's very interesting to hear all this side of it. But the big issue, I guess, in my mind, is obviously separate from the illness issues here, is if we can't mandate, which is generally the case, then you still have to manage the risk. And I can see that there's a few questions on there really about, well, what do we actually have to do, including, how much can we share in terms of, or find information about, whether people have been vaccinated or not. And if part of managing these risks in the workplace is to say, look, we'll fund you to get vaccinated, or we'll encourage you to do that. Obviously there's some risks around there in terms of, well, what if the person has an adverse outcome? And then as an overlay on that, Michael, and it'd be really interesting to hear what you think about, is like, it's not just the employer who's duty of care and the workers, or, the PCBU and the workers. So, how much does that duty for the worker actually require them to consider vaccination from that perspective? So I'm sorry to overload that with. You
mean the duty of care to each other, almost.
Well, not only to each other in the workplace, but to other persons as well. So, obviously there's privacy questions around, like, your own disability, or all these kind of issues. But in the end, workers need to actually take steps to ensure that they're not actually threatening the health and safety of other workers or persons. So I'm just wondering, how much that can actually be brought into this mix of managing what is, for most people, an inability to mandate vaccination, which in itself is probably not a panacea in any event.
Yeah, I might jump in, and I'd be interested in Mary Louise's views and yours, Jonas, as well, yeah, in relation to these issues. The starting point is that businesses have been managing a version of these issues for years, right? I mean, this is new in terms of its scale and nature, but managing conditions that workers might have that might have an impact to public safety has been part and parcel of the legal framework for some time. Mary Louise referred to HIV, and as we all know, there's a famous High Court case on the issue. But even leaving that to one side, epilepsy and truck drivers, train drivers. I mean, there are a number of those issues that we've been grappling with for years and years, and this is just an example of that, but at scale. We shouldn't pretend as if we haven't been managing COVID in the workplace in the absence of a vaccine. So that gives us a context. And I think in many respects, that context is important, because where a business might say that, look, we can't operate without doing things in a particular way. The reality is we're now 18 months with a COVID disrupted world where people have been operating without vaccination. So we've been able to keep people safe in that context, notwithstanding the absence of a vaccine. And I raise that not to discourage the mandating of vaccination in appropriate cases, aged care, hotel quarantine, hospitals, etc. Obviously, there are obvious examples, and we can get to whether aviation is in that category as well. And there's good argument why being in a plane with low ventilation might give you appropriate ground for those precautions. But even with the vaccination requirement, I don't think your duty of care stops there. I think you would still need to have the precautions in relation to maintaining safe distances in terms of people, social distancing, as it is colloquially called, looking at ways of eliminating the congregation of people or minimizing that as much as possible, maintaining the requirements in relation to hygiene and hand hygiene, etc. All of the precautions that we currently have in place at the moment, including taking a long and hard look about whether we need some flexibility in the workplace and having people work from home at least part of the time. I think that's part and parcel of the controls you've put in place, regardless of where you land on vaccination. So I think it's a complex environment where the vaccination is one piece of the puzzle. To some extent, what you're referring to, Janos, in relation to the duty of care of workers, in many respects, that reminds me a lot of the idea of fitness for work, whether in fact if you're not vaccinated, and therefore because of your working environment you might put other people at risk, that might go to your own duty of care in that respect. Certainly, if you're showing symptoms and you don't isolate yourself from the workforce, that certainly would be in that category. Whether vaccination is necessarily in that category might depend to a large extent on the nature of your work and the other circumstances that sit around that.
I might ask a couple of questions from the floor, because there seem to be some quite pointed ones, which probably help to expand this a bit. The first one was, does the HR department have the right to keep a log on how many staff have been vaccinated? And I presume the extension of that, which staff have been vaccinated?
Well, I mean, what underpins that is the justification for it. So, and the collection of data is one thing. What you do with it is another, which goes to the heart of the discrimination laws. Ultimately, if you're collecting data to discriminate against people, you're going to have to justify how and to what end you're using that. But if you're collecting the data for the purpose of putting in place safety measures, then that would be a different prism to look at that.
So, may I add a little bit more complexity here as well? Because even when and if we keep data on whether you're vaccinated, I'll just give you some sobering statistics or numbers. If you get Pfizer, you have about 10% chance of not eliciting an immune response. So you may have your HR document you as being vaccinated, but you could be one of that 10% that did not elicit an immune response. So you will be at risk of acquiring it. Now, we're not sure if you are also at risk of transmitting it, because maybe that 10% are less likely to have a high enough viral load. So we don't know. So let's assume that they could acquire it and transmit it as well. Then with AstraZeneca, it's a little more difficult because the numbers are so complex. On average, there's about 60, 68, 69% likelihood that you'll produce a good immune response. However, some other subgroups, it's as high as 80-odd%. So let's take the good. Let's say 80-odd% of us or 82% of us will be protected. So there's 18% that will never know that they're not protected, and they'll never know if they therefore are posing a risk to somebody else. So it's very complex, and it's not as easy as most other vaccines that says you're fine, you're not fine. With this one, yeah, you're vaccinated, great, and you've got a huge probability of being protected and protecting others from yourself. So that's great. But for some groups of employees, they may need to be tested every couple of days, depending on their exposure to their customers. And there are what's called rapid antigen tests. There are about 12 of them that have been TGA approved in Australia. There are many, many of them. And they are best used not diagnostically, not in case you've got symptoms, which the PCR test is both used as both screening and diagnosis, because when they call for people to turn up to be tested, those people that are turning up for tested, most of them never have any symptoms. So that's really called screening. So your viral load is quite high pre-symptomatic. And these rapid antigen tests look for the N protein in that viral load. And they're very good. They've got around 98 to 100% accuracy for labeling you as not infected, which is what you want for screening. So the staff who don't want to be vaccinated might need to have maybe every other day, because it's not nice having nasopharyngeal swabs every day. There are several types. So there's the PCR test that takes about 6 hours to get results. So that means that you basically got to have it at the beginning of the shift of how safe you are for your customers. But we don't know how safe you'll be when you leave home, because it takes 6 hours or so. But these rapid ones, you can do at the end of the shift or at the beginning of the shift. But the saliva one's about 80% accurate for diagnosing you as having the disease. There are rapid antigen tests that use both nasal or nasopharyngeal. So it's not nice, but it's a good thing to do if your employees could be at risk of giving it and also acquiring it at work.
Michael, could I ask you, thank you very much, Professor Mcclause, could I ask you a question related to what's been asked on the forum here? So if you want to ask a person whether they've been vaccinated or not, is that then going to be health information in a similar way to the Lee and Superior Wood case, where that person can potentially refuse to provide that information, and they're entitled to do so, assuming that the Privacy Act actually covers the organisation?
Yeah, no, that's exactly right. It is health information. That's not the issue. The question is, what are the requirements that you then put around that in terms of systems and processes, and what you make of the refusal. So which is why I was referring to about the discrimination issues inherent and associated with it. We've been collecting information about people for the purpose of fitness for work for some time. These the questions that we're grappling with here are not new in a sense. Again, it's just a question of scale. We haven't, we're not coming at this fresh. There's a lot of rich law associated with this.
So, Michael, one of the questions here is just that they've actually had issues with staff not wanting to share medical information. So if you actually want to get this information, noting all the kind of, whether it's good value or not, and you have a couple of staff members who say, well, I'm not giving it to you, like what's next steps then if this is something that you as a employer want to pursue?
Well, I mean, the question is, again, it comes down to what do you want that information for? It comes down to exactly the same considerations that we were talking about in terms of the risk assessment process, where this is required in order to protect the staff member, to protect an aged care facility, etc. And then that your inability to be satisfied that the person is not going to put others at risk becomes the decision point that you get to in relation to that person's ability to perform the particular role. You don't come at these things lightly, because one's view as to what is really fundamentally an inherent requirement of a job will differ. It's not from others. It's not just that you are in a workforce, therefore you're in a workplace, therefore you've got to be COVID safe. It's not that simple. One needs to actually work your way through whether in fact by performing a particular role without being satisfied that the person is going to put others at risk is really something that would prevent them or exclude them from doing that job. So
you've got to have it. Yeah, sorry, Michael.
Yeah.
So you've got to have a really good reason. So if you want the data and you're getting that data because you've identified a real work health safety risk, and that data is going to, reasonably assist you in doing that, then you'd probably, be entitled to push it a bit further, unless there's some other reasonable way that you could do so, which I guess is similar to those arguments.
Yeah, unless you can accommodate them into the role without having to press for that for that information.
And was that also when you talked about the role of government? There's an element there where this is where business is trying to take this on and trying to interpret it, whereas government could probably provide leadership in the space.
Certainly, the government can do a lot more in this space. I mean, one of the interesting things is that there are two documents that have been put out on this issue: the Fair Work Australia document and the Safe Work Australia document. Fair Work Ombudsman document and the Safe Work Australia document. And they're notable in terms of, their murkiness, in the sense that they say, well, you're going to have to go through pretty much the process that we've been talking about in terms of working out, whether in fact you can mandate vaccination in certain circumstances. And you've got to exhaust the risk management type of processes and discrimination processes. Certainly there is more room for clarity for the decisions in relation to the high risk areas to be identified in clear terms, and rather than leave it to each individual business to work those things out. There is always benefit in flexibility at a workplace level in relation to some of those decisions, but ultimately, I fear there's going to be a rich body of case law coming in terms of businesses overstepping the mark on one hand, or businesses failing to put reasonable steps in place to protect their workers or others. We've had high-profile inquiries recently because of those type of situations, whether it's the Ruby Princess or the Victorian Hotel Quarantine examples, and I fear that there's more in that territory to come in the absence of that clarity.
And I suppose the answer is similar, but in relation to workers, when you talk about when they're looking at coming back to office and they're worried about their risk of public transport and everything, I mean, what do you as an employer, what's your duty of care and what can you mandate? Is that a situation where you can mandate them coming back because you now have a public health situation where they can get vaccinated and it's a safer environment?
I mean, I'd be interested in Mary Louise's views on, because we've spoken about this, about whether in fact public transport falls in that category of in the same way as what an airplane might be, and it may not be in that same risk category in terms of train or a bus, that you would exclude people. Mary Louise, I know we're talking about that.
Yes, so we've spoken about this in depth. So on a plane, you're there for an hour or more at least, and the airflow change. You can't open up the window, you can't open up the doors, and even with a HEPA filter, the air has got to get to the HEPA filter first to filter out the tiny particles. And of course, there are many hours getting you onto the plane and getting you off the plane. So mandating, I think, particularly for overseas travel, is going to happen whether we like it or not. And of course, Michael will tell you that these people that are offering a service might be able to get away with this, although they might be taken to court to say that this is somehow infringing on people's rights, and they may therefore have to offer something like a rapid antigen test or a rapid PCR test, so that if you don't want to get on that plane with a vaccine, you can get on that plane with a mask, with a face shield, and with a test. However, I'll remind you that with the numbers going up in Queensland of positive travellers, their PCR that they had for 3 days prior to hopping onto that plane has either been slightly inaccurate or they've caught it in transit. So if you're in transit for quite many hours and you've caught it and then you're on the plane for quite many hours, you could still potentially, theoretically, transmit it to other passengers. If you've been only tested but not vaccinated, it's very difficult. So I'll leave that one to the lawyers. But I noticed that Michael on the Q&A has asked an interesting question about lawful and reasonable for a disability worker provided to be vaccinated. And remember, these workers are one-to-one, they're very close, they help people in and out of bed, they help people into showers, they cannot keep this physical distancing. So I think it would be reasonable, because I think it's reasonable to require residential aged care facility and frontline healthcare workers to have the vaccine. However, if somebody was willing, the disabled person was willing to have that person look after them, who also had a rapid antigen test every day before they came to help them, then that would, I guess, be a decision for the two of them. What do you think, Michael? Do you think that would be reasonable?
Yeah, I mean, it's an interesting debate, and you make a very, very valid point in relation to the use of rapid antigen tests. I mean, we like to kind of frame these arguments as if they're binary, but the law is not that simple, right? I mean, what is reasonable in the circumstances really comes down to what is available by way of controls. Which is why I said, we've been living without the vaccine for some time. Now the vaccine is an additional control. It's an available control. So then you have a decision making. You have a decision to make in relation to whether you should deploy that control. But also you have other controls that now are proving to be quite effective indicators. I think Mary Louise, you said to me it's 80% effective as an indicator. Now,
or even higher.
Or even higher. I mean, now you're getting into the territory, well, okay, that reduces the risk profile of that individual even further. I noticed one of the questions quite rightly says some people cannot get the vaccine, and they cannot get the vaccine for medical reasons, right? And so ultimately putting a requirement in relation to those people being vaccinated then raises another layer of indirect discrimination, because you are now singling those people out because of either a medical condition, disability, or a characteristic that is it's unlawful to discriminate against them for. And so again, it's not a matter of just being able to say, neatly put it in a box and say it's either everyone's vaccinated or no one's vaccinated, or even these category of persons are vaccinated or not vaccinated. You really need to delve into what else can I do, and have I exhausted all the possibilities of what would be available in those circumstances? And again, testing would be one example. And we know in the sporting context that actually, frequently testing people has become the norm in order for the players to play various sports, whether it's AFL or NRL or globally in the NBA, for example. And so that is one of the controls that could be deployed, and therefore one of the things you would need to exhaust before you get to the point where you say, I can exclude this person either from a service, or I can exclude this person from performing a particular job. And again, you don't come to those decisions lightly in terms of a job. You've got to really have the underpinning risk assessment and justification for it. And what I would suggest is you have to be on really solid ground in relation to it before you get into that territory.
Can I add to Michael's clarification? So the difference between the worker looking after someone with disabilities coming to a decision between two parties is one thing. But the reason I think that you either get vaccinated looking after residents in aged care facilities or they find you another job is because it's very difficult, because that aged care carer has many people they're looking after in a home with many people sharing that home. So that space is shared by many who may not be happy with coming to that decision. And I mean, it's a bit like, my home here. If I shared it with many, many people, and one person thought it was okay to have a carer come in, but I didn't, because they're breathing out, and most residential aged cares cannot meet the 10 airflow changes per hour per person for a regular size ward. And that's a very high airflow change, because some of these places are new, but some of them are not. They're houses that have been repurposed. So that is very different from having this one-to-one. And I noticed that one of the questions is also about the fly-in, fly-out mining sites. So here you could use your PCR test. Then when they get there, you could use your rapid antigen test every other day. And they don't need to be vaccinated, because they are now a city all by themselves, a community all by themselves, without people coming in potentially putting them at risk, if that's the case. And so somebody may choose not to be vaccinated without putting anybody at risk if they had testing regularly, particularly in the first week that they arrived, because I think they're there for sometimes months, with the fly in, fly out. And so they were safe. Then testing could stop unless a new group of people came in, and then you'd need to test them to make sure they didn't pick up anything.
It sounds very much like what you were saying, Michael. It's very much the effectiveness of the controls, and what controls you put in place, and whether those controls are reasonable. And in an aged care facility, the conclusion may be that the only control that's reasonable is vaccinations, whereas in a mine site, that's not exactly the same case. Yeah.
And it also goes, one of the factors that you look at in terms of that risk assessment is the impact of that contamination, right? So in an aged care facility, you've got a vulnerable community. Yep. And so the impact would make that risk assessment outcome a higher risk of a fatal consequence. Whereas a healthy group of workers in a mining site, you may not get to that same conclusion in terms of that outcome. So that dynamic is also, it's not just what controls are in place, it's also what are the consequences if it goes wrong. And the consequences in a hospital, in an aged care facility, because you've got a vulnerable community that if they get the virus, they might have a more adverse outcome. That makes the expectation on what's reasonably practicable for the business a much higher level, whereas other businesses may not be in that context, provided they put controls in place. So you look at the whole suite of controls that you can put in place.
It's the full control. So an interesting question that sort of expands on that was the one some of our customers are wanting to include in our contracts with them that our staff need to be vaccinated. So this is now where you start to get a legal obligation because of your customer's requirement. Interesting as to, I mean, what is the perspective there? Because that's going past.
I mean, it's going to be a fun world, where I'm sure a lot of people are going to be rushing to put clauses in their supply agreements. I'm sure a lot of people are going to be rushing to put, clauses in their employment agreements. I think there's a suggestion in some of the government guidelines to in fact do so. Look, we just got to be careful around this stuff and pump the brakes a little bit. I think the idea that you simply, it's so easy to put a contractual obligation, but ultimately, what does it even look like if people can't comply with that contractual obligation? And then all you're really doing is kicking the can down the road for someone else to deal with the very question that you're grappling with. And if they end up in the same difficulty that you're in, then you're still going to have those challenges. From a work health and safety perspective, don't lose sight of the fact that there is a duty to consult, coordinate, and cooperate that applies across overlapping PCBUs, persons conducting a business or undertaking, and then lose sight of the fact that there is a consultation obligation that applies to all workers, and that includes contractors. And so, the grand scheme idea of contractually mandating what you will have difficulty enforcing in a policy may be superficially attractive, but ultimately will prove ineffective if you can't get actual compliance with it. And then you're really, ultimately the contractual provisions are only as useful as your ability to then enforce them. And the enforcement will be in the context of a breach. And hopefully what we're trying to do is prevent rather than, attribute damages down the track. So I think I would encourage people to be more thoughtful than, again, blanket contractual clauses, as attractive as they might seem.
Brilliant. We only have 2 more minutes. I thought I'd just wrap up just by asking for a final closing statement from all 3 of you. And in particular, Professor Mcclause, it would be interesting to find out what do you think about the long-term outlook for COVID, given what's happening with COVAX and whether we actually see an end to COVID or if it becomes endemic. But I might start with Ines.
Oh, I can only agree with Michael here. It's such a complicated area that you can't give a black and white answer to. It's like managing an ill and injured worker. There's so many different overlays of laws. And then, of course, all the science behind it, Professor Mcclause. It's really, you just have to come down to the individual workplace and within the workplace, within the individual sections, and then down to the worker. I reiterate everything that both of you have said.
Thank you. Michael?
Yeah, for me, I agree with Jonas. I mean, ultimately, this is a minefield of overlapping and overlaying laws. I think we all know what the broader big picture public policy position should be, and that is as much as possible to try and get people to be vaccinated. And as much as possible, there's a role for businesses to try and do that voluntarily. If people are doing that voluntarily and you're encouraging your workforce to do that voluntarily, then you sidestep a lot of those legal complexities. But without that, I think it becomes incredibly challenging. And what then you need to do is make sure that the risk assessments stack up. There is thought behind your approach, and you triage through each individual case on its own merit, having regard of the role, the inherent requirements of the job, and what can be done by way of reasonable accommodation for that person, given their situation.
Thank you. And Professor Mcclause?
Oh, I can't believe a whole hour has gone by because the conversation's been great and the questions have been fabulous. One question, I'm sorry, I have to answer this one, is about mandating or providing home testing kits. So UK provides school children to be tested at home. TGA doesn't want us to have home testing at the moment, which is a bit sad, because I think that women have been using, and teenagers have been using, you know, pregnancy tests at home and dealing with the knowledge, the good or the bad knowledge of, that test kit gives. But I don't think that you can use this to then say, rather than being vaccinated, I'll test myself at home. Because if you don't want to tell people and you really think you've got to go to work, you can't trust those to do the right thing when they feel impelled to go to work. And we saw that happen in Victoria. So we will get other pandemics. Sadly, this is just one that has gone across the Western countries to now wake us up to this risk. We've had pandemic influenza in Asia, we've had SARS, we've had all sorts of diseases, and now this is, other than HIV, one of the first that has reminded people that we're at risk, and it's about how we respond. So the lawyers and the government are going to have to get together to think very carefully about how to respond for making it safe for everybody, not just the individual, and trying to give them, I guess, choice, give them choice.
Thank you, Professor Mcclause. Thank you, Michael Toomer. Thank you, Janice Blackmore. This has been a great hour. And thank you all the audience. We've had a large number of people on, and I'm looking forward to seeing the transcript after this. And I think we'll close it there.
Thank you.
Thanks all.
We'll stay on. I think we'll stop the live session in a second.